Hello, everyone. Today, we're going to be introducing the ABCs of DBT. This is just foundational learning for understanding the treatment of DBT. And we'll be going through all the different elements that make up a comprehensive DBT treatment. My name is Emily Williams, and this is my co-host, Jordan Crosby.
Hi, everybody.
So one of the first things I want to discuss is who all becomes included in DBT. A lot of the times when we think about DBT, what we first think about is borderline personality disorder. But there are a host of different behavioral disturbances that DBT treats. Some of the most prominent ones that it treats is suicide attempts, self-harm behavior, but it also looks at some other less known parts of individuals' behavioral disturbances. And that can include things like frequent mood changes, meaning having very rapid changes and intensities of emotions, difficulty controlling anger. Sometimes we work with kind of lashing out behaviors, verbal aggression. A lot of our clients have very unstable relationships. They might have friendships for very short-lived periods, even take on characteristics of that friendship and then hop to another. They might have very conflictual relationships. There might be efforts to avoid loss. And what I mean by that is oftentimes if our clients perceive some sort of loss, they will engage in some behaviors to try to reach back out to them. They'll have a sense of anxiety. They'll do a lot of reckless things sometimes to avoid losses. There might be impulsive behaviors. Those can include like drug use, alcohol use, reckless spending, unsafe sex. It can also be like online behaviors too, like reaching out to people who are older than them, much older than them. For our teenagers, it can be sexting. It can be giving out unsafe information on the internet. It could be things like uncontrollable eating or even like binging and purging, because DBT has been used to treat some eating disorders, running away, any kind of school truancy. It can also include things like frequent changes in how they see themselves. I think I mentioned just a little bit before that a lot of times our patients will adapt their identities to the people around them, because they don't have a clear sense of self. They might also have feelings of emptiness and have periods of dissociation. Now, there are some people that DBT is just not effective for treating. Some of those include the severe learning disabilities. DBT can be a very cognitive-based approach in some areas, and sometimes there's a disconnect in being able to impart the information and the processes that is just not equipped for people with those learning disabilities or cognitive impairments. Another thing is an inability to meet attendance. There are attendance requirements associated with DBT therapy because it really takes a commitment to the model in order to make those treatment gains. And those attendance requirements can come for a number of reasons. So sometimes our clients have medical issues that prevent them from attending. Sometimes they just don't have the transportation or the resources to come to group or to their individual sessions, but it is a very important part of the therapy that attendance occurs. Another thing that would exclude them from DBT therapy is just an unwillingness to work on their self-harm behaviors. In fact, when we first start the treatment, one of the first things that we do is we get a commitment to stop all self-harm behaviors while they are in treatment. And if we can't initially get that commitment of stopping, which is super important, we do make sure that they are willing to commit to working on stopping. The same goes for like not wanting to stop their substance use disorder or their eating disordered behaviors. Now, just because they commit to it doesn't mean their follow through is always as good as their initial commitment, but we work with that. But that initial commitment is super important to the process. Other one would be conduct disorder, psychotic disorders, or any parents that are not willing to work with their kids and work in the multifamily groups. Or sometimes, like in our case, we're not providing those multifamily groups right now, but we do provide family sessions individually to work on some of those teen and family conflicts.
All right. So DBT, I'm sure many of you have heard of it and are wanting to learn more about it. And so it is one of the few evidence-based approaches to treat people with borderline personality disorder. And it was actually developed by Dr. Marsha Linehan. And I think a really cool fact about DBT is that Linehan actually had a BPD diagnosis herself. And so very rarely do we see people creating a treatment for something that they themselves are affected by. And I think that that's just a really cool fun fact. But the evidence supports that DBT is helpful in treating borderline personality disorder, mood disorders, folks with suicidal ideation, and for changes in the behavioral patterns, including but not limited to self-harm and substance use, along with those other kinds of self-harm behaviors that Emily was just talking about.
So let's talk a little bit about dialectics. Dialectics are basically the idea that two opposing views can be true at the same time. So basically the idea is that people on a dialectic will polarize from one end of thinking to the other. And this image here represents the main areas in which we see the dialectics present. So for example, sometimes we have clients that come in and it's like they have a crisis of the week, right? There's always something going on. And then sometimes you'll see a whole lot of that. And then in another session, they might come in and everything's fine. Nothing's wrong. Everything is perfect. And they're just smashing down all of their feelings. And sometimes they'll end up on this seesaw. And our job as clinicians is to figure out where they are on this seesaw going back and forth. And we get on the other side in order to balance it out. So we are constantly moving back and forth because we're trying to help them meet in the middle. Another example might be this apparent competence and active passivity. What that just means is sometimes apparent competence means they come in, they know all the answers, they've got it all going on, they know exactly what they're doing. And then they're not admitting where their weaknesses are because they're saying that they've got it all together. And then they turn around and they don't know how to do much of anything. And they're just a victim of what all is happening. And so we're constantly moving back and forth. So like when they're saying they've got everything all figured out and life is great, it's our job to get on the other side. Okay. And here was an example of how maybe you had an opportunity to use a skill and maybe did not. And another really prime one that we use, and this begins like almost day 2 of DBT treatment, we start talking about this main dialectic in that our patients are doing the absolute best that they can, and they need to do better. And what we mean by that is that even though they probably are doing the absolute best that they can, the best that they can is not quite working for them. So we have to work to do better. So it's this constant balance between acceptance of the patient as is, but also like working towards that change. And we too, as clinicians, we bounce back and forth too as to where we're at in terms of our own experience with this client and learning to both accept them as they're presenting and motivate them to change, which is a constant challenge, right? It's always a challenge. It's a challenge for the client and it's a challenge for the clinician.
All right. And so whenever we are starting DBT with a client, we always go through these assumptions with them so that we're on the same page about where we're meeting for either the skills group or an individual. And so these are the assumptions that we present to them. And the very first one is that people are doing the best that they can. And so with that, we're really wanting to have that positive regard for our clients, and we're wanting our clients to have positive regard for others in their life, that we are all truly just trying to do the best that we can to get through. And the second is that people want to improve. And so oftentimes in DBT, we're working with folks who are engaging in behaviors that maybe we would call self-sabotage. And so sometimes it can be hard for us as clinicians to see that people want to improve, and they do. And sometimes it's misdirected, but they do want to improve. And this one is my very favorite one. And this is the dialectic that Emily just presented, but that people need to do better and try harder and be more motivated to change. And that, they're doing the best that they can, and they need to do better. And there's that dialectic. And within DBT, you'll hear us saying the word "and" a lot. And we kind of say it in a funny way. And that's how you know you're a DBT therapist. We're replacing all the buts in there and replacing them with ands. And that's just, I'm a grammar nerd, so I kind of love it. But the next one is, this is probably the one I use the second most, is that people may have not caused all of their own problems and they have to solve them anyway. So many of our clients have been through extensive prolonged trauma and are maybe still going through it, just long periods of invalidation, all forms of trauma. And so life has been unfair and life has been painful for the clients, and yet still it is their responsibility to come to DBT and to use their skills and to make those efforts to improve their life. And it is unfair, and yet it is still their responsibility. It is the next one. The fifth one is that the lives of emotionally distressed individuals and their families, those are painful and as they're currently being lived. And so the lives of our clients and the lives of the clinicians and the lives of everyone, they're painful. Life is inevitably going to be painful at some point for anyone. And we can't deny that pain of our clients. Number 6 is that people must learn and practice new behaviors in all the different situations in their lives. And so, we'll speak more to how we're putting this into practice with our clients. But we've got to change the behaviors using the skills that we learn in skills group to create the change for that life worth living that our clients are wanting to achieve. Number 7, there's no absolute truth. DBT does not believe in the world of absolutes. We're all on a spectrum of different beliefs. And to balance those seesaws, there is no absolute right or wrong. We're moving away from that polarized thinking. So there is no absolute truth. And really, DBT is not about finding the truth. It's about finding balance. And number 8, people cannot fail in DBT. If you've got a skilled clinician who is doing the model as they're supposed to with all the different components, and the clients do not meet any of the exclusion criteria for DBT, they cannot fail. And I think that that's really, really cool. There is no failure in what we do.
So there are several different components to DBT therapy. The first is the skills training group, which Jordan just mentioned, which just helps focus on teaching our clients to avoid self-sabotage. And that skills training group has different units. So the main one is mindfulness. And mindfulness is about teaching our kids how to be in the here and now. And I say kids, but I also mean adults. Be in the here and now, And then also become more aware of how their body is responding and how their body is being in that here and now, rather than always living in the future or thinking about the past. We're looking at what shows up right now, and that is a discipline. And there's a bunch of different skills that we teach our clients in order to be in the here and now so they can figure out how they're responding to things in each different moment. Then we have the emotional regulation skills. Emotional regulation skills are basically teaching our patients how to balance their emotions and how to manage them. Then we have interpersonal effectiveness skills, and these skills include ways for our patients to improve how they relate to others and improve their relationship with themselves. Then we have distress tolerance skills. These skills are there to teach our patients how to manage major feelings of distress without having to do risk behaviors in order to manage them. And then finally, we have walking the middle path skills. And this is about our family and teenage challenges. It's not really for the adults unless those adults have children too, which it might also be helpful in those cases. So the skills training group usually meets once a week for about 2 hours. It can be a little bit less or a little bit more depending on the program, but that is the general timeline by which it meets. The second component is our individual therapy. Individual therapy is there to help target the self-sabotaging behaviors. But let me kind of rewind just a little bit too. Like in the skills training group, we really don't focus on the risk behaviors. We focus on the skills that we're teaching. And the reason is we don't want to trigger our other clients while we're in skills group. So rather than dealing with those issues in group, we bring the actual targets, the self-harm, the substance use, and other stuff into our individual sessions so that we can directly target them and start to begin to work with our clients to build skills and know when to implement them. So we definitely do the skills reinforcement, and we do some role playing. We might assign some in vivo practice. All of our patients get a diary card. Those diary cards will monitor the use of skills. It's kind of like a checklist, but we'll get into that and show you that a little bit later. And then the clinician acts as the reinforcer. So our relationships with our patients is probably the most important element of DBT therapy. So how we respond to our patients when they are presenting things can either reinforce what they're doing or provide no reinforcement. And so we're constantly working to make sure we reinforce effective coping versus ineffective coping. The third element of DBT therapy is the consult team. This is where we all meet together in order to review our work and kind of get feedback as to how we are doing. Now, consult team is here for the therapist, kind of the therapy for the therapist. If you work with borderline patients, you know that working with them can sometimes be dysregulating, in that if they're on one polarized end of the spectrum, sometimes we too have a natural tendency, just like their parents, just like other people in their life, to polarize on the other side. And so consult team is there to help us realize when that is happening and then kind of move back to the middle. Is also there to kind of problem solve different cases and generate ideas on how to approach a patient. And then the last element is phone coaching. Phone coaching, the idea behind this is if you're at a basketball game and you are in the middle of a game, it is more effective if you can, in real time, provide that person coaching on what to do versus expecting them to take everything from practice and just go out into the world and be the best basketball player ever. So phone coaching allows the patients to call in real time when they're having a situation and practice use of skills, because quite frankly, sometimes when you have dysregulated individuals, being able to pull from those skills can be really difficult because we don't think the best when we're all emotionally dysregulated. And the idea behind phone coaching too is that eventually, when you use it enough, eventually you start tapering back because now it has become a habit.
All right, so these are the links between the units from our skills group and the challenges that those are acknowledging and assisting in. So one of the first problem behaviors that many of our clients and their families are looking to decrease is this reduced awareness and focus and confusion about self or identity. And so many of our clients are maybe not always aware of feelings and why they're upset. They have trouble articulating their goals, and they have trouble staying focused in their lives. And so that's really where our core mindfulness skills come in. And like Emily just mentioned, the mindfulness skills come up time and time again because it's really the foundation of all of the other skills. And so we're doing the other units in succession, and with every single unit, we're doing core mindfulness again because we do believe it's that important. That next kind of problem behavior or target behavior that we're wanting to decrease is the emotional dysregulation, those unstable moods, mood changes, intense moods, where many of our clients maybe have little control over them, or even just a steady negative emotional state, or the client's engaging in what we call mood dependent behaviors. And so this could be really acting out of what we call the emotional mind, with those impulsive sort of behaviors, or feeling so angry that they do something that's self-destructive, or so sad that they do something that's harmful to themselves or others. And that's really where we're using our emotional regulation skills. The third one is impulsivity. And that's when our clients are acting without thinking through what they're doing, or using behaviors to escape or avoid negative emotional experiences. And so that's where we use our distress tolerance skills. Our fourth one are our interpersonal problems, those unstable relationships, patterns of difficulty keeping relationships steady. Our clients sometimes have trouble getting what they want in relationships, or telling someone no, keeping their self-respect. And a lot of our clients report feeling lonely in their relationships. And so this is where we use our interpersonal effectiveness skills. And finally, we have the family and relationship challenges. And so this is for our adolescent clients and their families. But this is where between teenagers and their adults, we have extreme thinking, feeling and acting. We have absence of flexibility, very rigid structures within the family, difficulty navigating the family relationships, conflicts, or not even, effectively influencing others' behaviors. And so this is where, sometimes our parents are punishing kids in ways that maybe aren't as effective as they could be, or kids are asking their adults for things in a way that's not super effective, as teenagers tend to do. And this is where we use our walking the middle path skills.
This is the DBT house of treatment, and this house kind of outlines the stages of treatment that a person goes through as they work towards wellness. So, I really, really love this graphic because it is such a good way of showing how people move through to get that life worth living. And so when patients first come into treatment, we talk about getting those life worth living goals, like what makes your life something that you really, really want to do. And so through this house of treatment, what we're doing is we're working up each stage of the ladders in order to get that life worth living. So if you look here at stage 1, this is usually where our patients are the most emotionally dysregulated. There's severe behavioral problems, lack of control. And as you can see, it looks like here there's fire down here at the bottom. So the idea behind this is that basically our patients are in the basement in fire. And the only way to get out of the basement is to go up the ladder. Now, the ladder is made of metal, which means it is going to burn really badly to get out of the basement. But it's the only way out. So we know that it's going to be painful for our clients. And yet we're here telling them and coaching them, like, we've got to get you out of the basement so that we can start to work on building the life that you want. So here's where we're working on the life-threatening behaviors and threats to treatment, because our patients often engage in a lot of therapy interfering behaviors like not showing up or failing to come to group or not implementing their skills once they get out of there, or a lot of resistance in session where they want to talk about 7,000 other things except for the treatment that they're supposed to be working on. I mean, there's a lot of different therapy interfering behaviors. It's also where major threats to the quality of their life is also discussed. And these can be a whole host of different things. It might be that they stop going to school because that will end up impacting their future, and that really threatens the quality of their life. And then this is also the place where we utilize our commitment strategies and help them make a commitment to therapy and working through the program. And those commitments are like so super important and vital, because when we have emotionally dysregulated youth, sometimes all we have is their commitment to leverage their engagement. And then we also teach the skills, and then we set contingencies. And what I mean by contingencies is we find ways to say, if you do this, then this is what happens. And we help them with that. And we also do that within the therapeutic relationship as well, is we're constantly looking for ways to set contingencies. So let's say a patient hasn't shown up for 2 different sessions in a row. We set a contingency that if you want to come back into therapy, I'm going to need you to turn in all 3 weeks of diary cards and be able to explain to me what got in the way and how you're going to solve this problem in the future. So we do that. Then finally, if we can coach them up this burning ladder, and trust me, it's not going to be pretty. It never is. If we can coach them up this burning ladder into stage 2, this is where we get to the root of the issue. So we're stabilize our life. We're no longer trying to self-harm. We're no longer having these ongoing suicide attempts. We're no longer like lashing out at all the people around us. We're no longer, talking to 75-year-old men when we're 13 about our sexual prowess or whatever the case may be. I've seen all kinds of different things. So this is where we work on the PTSD. The recommended treatment at this level is prolonged exposure. It's the one that's been most researched, but it's not necessarily the one that everybody uses. So for me personally, I use EMDR at this stage. So we work through the DBT, we stop all the risk behaviors, and then we move into processing the trauma. Now, all the while you're processing the trauma, you're still doing those diary cards, you're still continuing those skills, because if you think about it, when you start bringing up trauma, what do we tell everybody when we start trauma work? What happens is things get worse before they get better, right? So now we're digging back in the stuff and we're kicking all this stuff up. And now they've got all of these skills to implement when that starts to happen. So we work through all of the trauma, and then we work up to stage 3. And this is just like working out some of the problems in living everyday life. You're trying to achieve that ordinary happiness and unhappy, a nice balance. So you're working towards life goals. What do you want for yourself? You want to increase your self-respect. Like, How do you make decisions and maintain your values, and what type of relationships do you get into, and how do you engage with other people, and all the while maintaining your goals and your self-respect. And then finally, and not everybody gets to this level. This is the final level of DBT treatment. And sometimes insurance doesn't pay for this level. So just heads up on that. This is stage 4. And this is basically the area that they work in to expand their awareness about the world around them, how they fit into the world around them. This is their spiritual fulfillment. And the whole point of this area is so that they have the capacity, not just for the ordinary ups and downs of life, but for sustained joy, to always feel okay in all situations, and have that connectivity to something bigger than themselves. And the whole idea around it is you're looking to solve that sense of incompleteness and fill that void that is left. And that is considered the peak experience. Now, Marsha Linehan, she went up through this top layer. It's her treatment, right? And what she did to get to this final layer is that she went and did lots of mindfulness retreats. She talks with monks. She found ways to have like a higher sense of purpose, a higher knowing, a higher awareness. And guys, sometimes even clinicians haven't reached this level. So just to kind of give you some context about what that means.
All right. So our first unit within the skills training is our mindfulness unit, which is our core unit that we're repeating before every other unit within skills group. And so the first skill within the mindfulness unit is the wise mind. And so you see this Venn diagram up here, and wise mind is that golden space between the rational mind and the emotional mind. And so that is a dialectic in itself, that we can both be rational and we can have our emotions validated by ourselves. And that union is where our wise mind lies. And it is a really, really cool thing. And this is, pretty much the first skill that our clients are learning. So a lot of our clients really kind of resonate with this skill, and will use wise mind while using all their other skills. And so there are 2 sets of skills that we use to be able to achieve wise mind, because you can't just really flip a switch in your brain and be like, all right, I'm in wise mind mode. It's a lot harder than that. It's kind of a practice in itself. So the first set of skills are the what skills within DBT. And those are all about observing, describing, and participating. So with the what skills, you can only do one at a time. So observing is all about observing what's going on both within your body and outside of your body. And so observing those bodily kind of sensations, observing what's going on in the room around you, just really kind of taking a minute and just taking it all in. Describing is about putting words to that experience. And it's about I'm kind of taking observing and moving it to the next level. And participate is about getting into the experience and not letting things outside of you kind of draw you out, and really just fully getting into it. Finally, the how skills. And so the how skills, you can't just do those one at a time. You can do them a few at a time. And those are telling you how to do those what skills. The first being one mindfully, that you're focused on doing one thing at a time, non-judgmentally, that you're not trying to pass non-factual judgments onto things, and that you're seeing things for what they are, and doing what works. So doing what works means that you are thinking about the systems that you're present in, the rules that you have in your culture, or taboos that are in your culture, and doing things that are getting you closer to your life worth living. That you are using skills that are moving you forward, and you're thinking about the context in which you're using all of these skills.
So the next unit that we mentioned was emotional regulation skills. And other than the mindfulness, like you can actually change the order in which you present the other skills modules, but mindfulness is the first 2 weeks of every single skills module. So that repeats all the time. So there's no set order by which you can present, just as a caveat. So some of the goals of emotional regulations is to first, you got to understand the emotions that you have. So we teach our clients to identify what their emotions are and then figure out what the purpose is. So like if you're scared, the purpose of that is so that it motivates you to get out of a dangerous situation, right? And sometimes it's super useful. And sometimes when you're scared of giving a DBT presentation, it kind of gets in the way, right? So understanding the emotions and what they serve you to do. Then we work on reducing emotional vulnerability. So basically what we're looking to do here is just increase the experiences of positive emotions, and decrease the vulnerability to emotion mind. So like Jordan was talking about with emotion mind, like when we make decisions purely out of emotion mind, sometimes those decisions are not all that great for us. So it's super important that we recognize that emotion mind can sometimes lead us astray, and we want to reduce the vulnerability of staying in that space. Next, we want to decrease the frequency of unwanted emotions. So, if we have a lot of things like anger or fear or anxiety, or all those things show up at times and places where they're not really necessary or helpful, then we figure out ways that we can decrease those experiences. Then we also aim to decrease emotional suffering, so that we can stop unwanted emotions once they start. So, how to experience them, invite them in, allow them to happen, and then change them through opposite action. And as we go through our different training modules, we'll go far more into those individual skills. So the types of skills that we teach in emotional regulation include, first, we already mentioned the emotional identification. What is that feeling? And I don't know if you guys have ever seen that emotion wheel, Pachaska's emotion wheel, but oftentimes I will pull that out and I'll be like, all right, let's look at the nuances of these feelings, because they have different motives, do they not? They have different urges attached to them. So again, identify purpose of emotions. The third skill that we teach is ABC Please, which is a very long skill. It is accumulating positive experiences. So purposely inserting positive things into your life. In fact, Jordan makes appointment cards for it. I have not done that yet, but it is definitely a great idea, to put in short-term positive experiences, and then also figuring out how you can begin to like have more long-term experience by developing goals and then figuring out small steps, which feels good, right? Then there's building mastery. So if you want to develop some kind of goal, like in working towards it incrementally, and that too goes back to your diary cards, right? So like every time you fill out a diary card and you try a skill, you get better at using that skill. Then there's cope ahead. Cope ahead is basically just imagining an experience happening and then working through it using your skills. Balanced eating, very important. Like, I don't know about y'all, but it is not pretty when I am hangry. Avoiding mood altering substances, getting balanced sleep, getting exercise. We teach the wave skill, which is just the idea that emotions can come and go without having to interact with them. Check the facts and problem solving. Check the facts just as looking at purely the facts and not our interpretation of facts, and then figuring out what to do. And then opposite action to change emotions is the idea of experiencing emotion and then doing the opposite.
All right, distress tolerance. This is one of my favorite units, which I say they're all my favorite. It's kind of the joke that Emily and I have. But the goals of distress tolerance are all about reducing the avoidance of pain, because many of our clients have learned that life is painful and will take great strides to avoid the pain. And that's really where a lot of the self-harm behaviors come in. Uh, Another goal is to reduce the impulsivity as a method for reducing pain. So many of those attempts to reduce the pain end up being really impulsive, like using substances or risky sex or cutting or any of the other behaviors that we've kind of discussed. We're reducing behaviors that hurt oneself or others, like the ones we've been talking about. And then finally, we're reducing behaviors that decrease the likelihood that you get what you want. And that's those self-sabotage kind of behaviors, like we call them. So the skills that are present within distress tolerance, the first is the distract skill, or it's accepts. And really that the purpose of it is to distract. And so these are different methods that we can use to distract ourselves from those distressful sort of thoughts or emotions. And so those include engaging in different kind of activities. Those can include contributing positive things to other people, comparisons. If you've done this before, then you can do it again, or other people have a much more difficult position right now. You can get through this. Emotions, doing things that create a more positive emotion in you, pushing away. This does not mean repressing negative emotions or distressing emotions or thoughts. This means taking a temporary vacation away from them and coming back to them when the time is more appropriate. Thoughts, just thinking about something different. And then finally, sensations. And this is where we use our self-soothe skill, which is our next one. And these are about finding bodily sensations that can take our mind off the distressing thoughts or emotions. So with self-soothe, we're targeting 6 senses and not the horror movie, The Sixth Sense, but it's the 5 normal senses. And then the 6th sense is movement. And so we create little kits, like physical literal kits that our clients use to target those different sensations. And so one of my favorites to do, because it's kind of fun as a therapist to see my clients do this, is I get a big bag of Warheads or hot Cheetos, or my other favorite one to do this with. And so really spicy food or really sour food can get your mind off of the other things that are going on. Or if I have them lemon. So before in group, I've had clients like bite into a lemon, and it's really hard to feel sad if you're worried about like puckering up on a lemon or a Warhead. And so our next skill is our improve skill. And so while all of these distress tolerance skills are not really about making huge changes, they're more so about surviving the moment. Improve is really targeted at changing the thoughts, whereas distract or accept is about distracting from the thoughts. And so improving, you have positive imagery. And so we do, or I do like a safe space meditation with my clients, finding meaning. This is sort of like finding the silver lining in the moment. Prayer. I have a lot of clients who've had religious trauma, and so I'm very careful with how I explain this. But for religious folks, this may mean prayer to your being of creation or higher being. But prayer for people who do not have a belief in a higher meaning could be prayer to their wise mind self or the best version of their self. Or I've even done it with someone who's meaningful to them, but reaching out to that ideal self or creator. Relaxation, it is what it sounds like. Really taking a moment to relax some of those distressful emotions. One thing in the moment, I don't know about you, but I'm a highly anxious person. And so I find myself when I'm anxious, I'm trying to do 55 bajillion things at a time. So one thing in the moment is about doing literally one thing in the moment, and not worrying about everything that's to come and everything else that's happened. Vacation, this is another one that I use a lot in my own life. And while going to the Bahamas, every time that you have a problem or every time you feel anxious is great. This doesn't necessarily mean a for real vacation, but vacation more so means like a mental vacation. So if you are in a really challenging, I don't know, like going to the DMV and you're in line and it's taking forever. My body may be in the Spartanburg DMV, but my mind is in Iceland looking at a waterfall. And so it's about taking mental vacations is really kind of a good way to look at it. And then encouragement, these are using cheerleader statements to encourage yourself. And so sometimes I'll have with clients, they will write themselves notes of encouragement and they go back and look at it. Or I'll even have them think about like, what would your best friend say to you in this moment? Or they literally could have notes from like their best friend that they go back to and read. And they're like, oh yeah, like I can do this. It's another one of my favorites. Pros and cons. This one is really targeted towards decreasing those self-harm behaviors. And so we're looking at the pros and cons of engaging in impulsive behaviors versus using skillful behaviors. So really, impulsive behaviors tend to have short-term pros, but really long-term cons. So a short-term pro of cutting is that you feel a new sensation and you're not thinking about your breakup, but a long-term con maybe that now you have to miss watching Survivor on Wednesday nights because you're in group therapy. Or it may mean that your family doesn't trust you. Versus with skillful behaviors, there may be some short-term cons that they're kind of a pain in the butt to do, and you've got to go to group therapy every week and you got to learn all these acronyms and stuff. But the long-term pros are that you have the mental stability to be able to go off to college and your family not worry about you cutting while you're at college. So you get to achieve your career goals or you have more stable relationships, those sort of things. Tip, I think these are some of the most fun ones to do. These are skills targeted towards physiological responses to distress. So temperature, this one is using cold temperature on the vagal nerve, and it decreases distress by lowering the heart rate and lowering your blood pressure using the mammalian dive reflex, which is really, really cool. Intense aerobic exercise. If somebody's feeling really, really suicidal and about to cut, exercising is a great thing to do because it gets those distressful emotions kind of out of your system. Paced breathing, of course, doing breathing exercises, and then progressive muscle relaxation, tensing and releasing different muscles throughout the body, kind of in a pattern. Radical acceptance, by far the hardest skill of any of them. And Emily and I often have moments where we're reminding ourselves of how to radically accept things. But this is really accepting things, people, events, feelings for exactly what they are and realizing that some things can't be changed and we just kind of sit with them. And my like kind of uncouth way of saying it is that you kind of sit in the shit and you allow for it to happen and to be. And it's okay. And then willingness and willfulness is all about allowing the world to be what it is and do what's needed. Willingness is going along with it, and willfulness is doing everything in your power to not allow the world to be what it is, and kind of fighting back and it ending up kind of hurting yourself because you're not going along with maybe the way that it would be easiest to use skillful behavior.
The next segment is the interpersonal effectiveness skills, and the goals of this segment is to keep and maintain healthy relationships. And so we teach our clients how to evaluate relationships, how to set boundaries, how to get somebody to do something that they want, how to make requests, and then also to maintain their self-respect. Oh, did I skip one? Yes. Okay. So the skills under the interpersonal effectiveness skills include the give skills, which is basically just how to talk to people, right? So it includes being gentle, acting interested in what somebody says, validate their side of things, and just have an overall easy manner. The dear man skill is the skill used to get people to be more likely to give you what you want, or how to say no to something without causing too much of a rift. So it includes like describing the situation, expressing your feelings about it, asserting what you want, and then reinforcing what you want, right? So if you do this, I'll do this. And then also like how to present it as well. So then you have the man skills, which is being mindful of what your ultimate goal is, because sometimes when you're asking for something, people will pull you in a million different directions. So staying mindful, appearing confident, and then also the willingness to negotiate if they cannot say yes to a request, or if your no also has some difficulties related to that. Then there's the fast skill, and the fast skill is how to stick to your own values and assert yourself when it comes to values. So, how to be fair to the other person. If you do have to say no to something, don't apologize for it. You can stick to your values, but stay truthful without trying to make excuses for why you're saying no to something. We work on assessing worry thoughts, and we do these through using wise mind statements. So we'll look at some of those worry thoughts that show up, and then we will create some wise mind statements that turn them into much more realistic thoughts. We'll go through how to say no and what kind of things to think about when you're asking for what you want. Things like, do you know what your priorities are when you're asked? Do you know if the other person even has the capability of giving you what you want? Did you wait for the right time, or did you wait till they were all up in their favorite movie and then you went and asked? Did you prepare? Like, are you able to answer questions if there's follow-up? Did you consider the relationship? You're not asking your teacher to loan you $500, right? But you might ask a close friend or even a family member for those things. And then also the idea of like, there's a give and take. So if you take more than you give, then you may not engage in that asking. And then finally, the think skills. The think skills are there in order to help a person think about motives of other people a little bit differently. And that's because a lot of our clients often attribute negative motives to people just for setting limits or for not giving them things that they want. So we teach them how to think and have empathy towards others. Be mindful of their own interpretations, notice things about them where maybe their interpretation of the situation, there were previous times where that may have been proven that that wasn't true. And then finally, even if they are having a bad day and there was some kind of funky motives because they were irritable, expressing some kind of kindness towards this person.
All right, so our final one, and remember this is only the one for our adolescent clients and their families, is the walking the middle path skill. And the goals of this skill are all about, is all about thinking dialectically and approaching those dialectical dilemmas, those seesaws that we've talked about, recognizing thinking errors, recognizing what's typical or atypical for behaviors within adolescence, what is typical kind of rebellion in teenagers and what is more atypical. What do we need to kind of get under within the parameters of what's typical? Validation skills. How do teenagers and their adults validate one another and their needs and their feelings? And then finally, the behavior change skills. So using reinforcement styles, extinction, shaping, punishment, all those kind of things.
Did I skip it? Nope, that was it for that one. Okay. And then we move into individual therapy. So individual therapy has several different elements, especially and most importantly, when they first come in, you engage those commitment strategies, and that is to get them committed to the therapy. And then even after they first come in, you get them committed to the therapy. I'm going to be honest with you, at some point in time, they're going to want to quit. They do it every time, or they're going to say it's not working, or something is going to come up. And so at that point in time, you reuse those commitment strategies and you remind them of their commitment to seeing it through. You remind them of their commitment to stop self-harming. You use these commitment strategies ongoing. The next part is finding the targets. Like we already talked about the life interfering behaviors, the therapy interfering behaviors, and the quality of life interfering behaviors in our house, our DBT house. So this is where we find those targets and we start to really define what we're working on. The diary cards are given out each week. They track and monitor the moods, the skills, impulses, and urges for risk behaviors. And when they do their diary card, they actually bring it back in. And if you see where they had an urge or you see where there was some difficulties, that's when you pull out the behavior chain analysis. A behavior chain analysis is basically looking at what events prompted risk behaviors, and not even necessarily risk behaviors. Sometimes it can be something like not coming into session. How did you not get there? So it could be therapy interfering behaviors as well. So you target those and then you go through a series of where did it start? What made you more vulnerable to that happening? And then you go through everything that got you up to the point that the behavior actually occurred. And you analyze it and you look at where you could start to implement those skills. And then after that, you also look at once they did the behavior, what were the reinforcers? So if you didn't come to therapy, what were the reinforcers? Well, maybe you didn't have to talk about something that you were uncomfortable talking about. Maybe you got an extra hour of sleep. Maybe, I mean, there's like a whole host of different things that they can report. And then you also talk about the long-term consequences of that. And you start to help them figure out how to remove some of the reinforcers for their risk behaviors. And then also creating that dialectical seesaw, which is like the meat and potatoes really is a lot of this seesaw stuff. So they come in and they've got this major issue and you are constantly moving on the other side of the issue. But without invalidating, right? So you're validating and you're accepting it, and then you're offering the other side of the seesaw perspective. And then when they come in the next time and they're on the other end of the spectrum, you start offering the other side of the spectrum, and you keep balancing back and forth.
All right. So Emily had just referenced these commitment strategies. Emily and I use these all the time. And so, like she said, our clients are often having an urge to quit. They may not be using their skills. They may not think it's useful. Sometimes we use the commitment strategies that they're not doing their homework or they're not engaging the responsibilities that they need to within their family. So these are some of the examples of them. The devil's advocate, where it's like, well, maybe you didn't even really, maybe, maybe DBT is too hard for you anyway. Maybe, maybe this is just too much. The foot in the door where, you're like, well, just, give it a try. Come to one group, try it out. If you don't like it, then, whatever. Door in the face is the opposite, where you're asking a client to commit to not engaging in self-harm for the rest of their life. And they're like, oh no, like, and then you're like, well, can you do the next month? Kind of moving from big to small, whereas foot in the door is small to big. Prior commitments. I do this one a lot with teenagers who are athletes or who are in like different kind of clubs or organizations, where I'm like, if you're able to do all of that conditioning with baseball, then I bet you can come to DBT group. Or with adults who work or teenagers who work, where it's like, if you're able to work a 12-hour shift at such and such restaurant, I bet that you can do an hour-long session here. Pros and cons. This is the same pros and cons skill that I was just talking about with distress tolerance. But what are the pros and cons of you being in DBT group versus you continuing to, say, use substances or engage in risky sexual behaviors? Shaping is all about shaping the behaviors using conditioning and contingencies and all those kind of things. Presenting choice is that DBT and really all of life is all about choices. And so providing them options and making them feel like they're empowered to choose to use these skills and to engage in DBT. And then finally, cheerleading, which is using our different validation techniques to really kind of like pump up our clients to engaging in DBT and using their skills.
This is our very fuzzy diary card. I just wanted to put it on here so that you guys were able to see kind of what it looks like. So up here at the top, even though you really can't see, this is where like the self-harm urges and actions are monitored. So like the urge is rated on a scale of 0 to 5. Actions, either yes or no, did it happen? And also there'll be like suicidal attempts. There's drug use, alcohol use, risky sex. And in those, like, you'll see the clear little boxes, like different people have different things that present for them. And so you can actually add something into the boxes here that you want to work on. So for example, I had a client not too long ago that like constantly seeks reassurance out from the boyfriend and does not feel okay unless they get it. And so we have to reduce that constant reaching out. And so that was placed on their diary card. And we're currently working on that. On the right hand side, on the right half, at the top, you'll also have like different emotions that you felt throughout the day. So anger, sadness, shame, just a whole host of different ones. And so they track them. So now you've got a mood tracker daily. You have urge tracker daily. And then down at the bottom is the list of all the skills that we teach. And so we ask them to circle what day that you use them. And so every day they're looking at their diary card, they're looking at it, they're being reminded of the different skills that they've learned. They're actively trying to implement them. And sometimes too, even in individual therapy, I'll even say, hey, this week, I want you to try this skill at least 3 times, and I want to see it on your diary card.
All right. Yeah. And these are kind of just the purposes of the diary card. Like Emily said, we're monitoring the risk behaviors or other target behaviors. And so for this particular client, reaching out to the boyfriend, but this could also be procrastination. This could be disordered eating behaviors. This could be really a whole wide array of different things. Tracking the mood, tracking their skill use and their willingness to use the skills and the efficiency of the skills. Whether they're doing the diary card daily or are they doing it right before they are entering group, in order for a client to come into group, they need to have completed their diary card. It's kind of an entry ticket. So are they doing it right before they come in? And obviously, if they're trying to remember back a week, they're not going to get all the skills and they're not really thinking about it daily. Whereas we're wanting them to be completing that diary card daily. And they're marking that there. And this says that they must be completed before individual sessions. It kind of depends on the layout. On the layout that Emily and I had before was that the diary card had to be turned in before group, but it certainly can be done with individual too. And really the whole purpose of the diary card is to help us do our behavior chain analyses to see when you do this, this is what happens and how can we make this go better next time.
And just another side note on the diary card, real quick, is like, I don't know if you guys have ever done like a calorie counter or a tracker of some sort, but just like that awareness, that constant awareness, and the fact that you have to write it down actually is a motivator for getting those uses skills. So next we have to find the targets. And I think I already mentioned this. So the targets for treatment, the first thing that we absolutely must do is the life interfering behavior. So always, always, always the self-harm, the suicidal attempts, all of those are top priority. The second priority is the therapy interfering behaviors, because we can get to quality of life stuff later, but we can't do that if they're interfering with their own therapy. And these therapy interfering behaviors, they can show up in a whole host of different ways. Like I said earlier, it could be that they don't show up for therapy, but I've had other things show up. Like I would have a client who would just ramble on and on and on about like something their mom did. And then when I tried to redirect them back to like what we were talking about, they'd go right back. And then I'd spend a lot of time like redirecting. And so I finally got to the place like this went on for about 3 sessions, and I finally had to set it as a therapy interfering behavior and like, look, when you keep doing this, it's interfering with our ability to actually focus on the work. And so I will save you 5 minutes where you can talk all you want about the random thing, but for the other 55 minutes of the session, we're going to be working on this. And so sometimes she would go back to that rambling, and then we would do a behavior chain analysis on it so that we could correct it, right? So therapy interfering behavior comes in all shapes and sizes. It can be that they say things to make their therapist mad. It could be sometimes even like therapy interfering behaviors has nothing to do with the client. It has everything to do with the clinician, right? So sometimes we get sidetracked on something funny that our clients said, and then we're going into this whole thing, we get our own self off track. So we have all kind of different ways that things get in the way of the therapy. And so not only are we working on this with our clients, we're also working on this with ourselves. And that's super important because DBT is not just therapy for the client, but also therapy for the therapist who is treating the client through their consult group. Then we work on quality of life interfering behaviors. So anything that is getting in the way of this client getting the life they want. It could be anything from engaging in arguments with the teachers to sneaking out of the house or whatever the case may be, whatever it is that's getting in their way of reaching those life worth living goals.
All right, and this goes back to our treatment stages of DBT, and this relates back to the house, of course. That first stage is where we see the majority of our clients, and this is kind of like trademark DBT, I would say. But the targets for stage 1 are all about decreasing or eliminating those life-threatening behaviors. So these are the suicide attempts, the suicidal ideation, self-injury, the homicidal ideation, aggressive behaviors. This could also include some like substance use stuff or other like really risky, life-threatening sort of behaviors. These are the stages also about decreasing or eliminating those therapy interfering behaviors that Emily was just talking about. So the missing sessions, When we were both in schools, them skipping school, so they were missing their sessions, but this could also be them not doing homework. Therapy interfering behaviors could be for an adult not asking to get off of work in time to be able to go to their sessions, or behaving so that others can burn out. So like really kind of like just the approach that they have with their therapist. Are they trying to wear the therapist out? And then of course using hospitalizations as a way of handling a crisis, that they're always wanting or always being placed into the hospital rather than using skillful behavior to stay out of the hospital. With that, reducing or eliminating hospitalizations is a major goal of this stage. Hospitalizations are expensive, and also with where we are in the pandemic, the room in the hospitals is limited, and the nature of the care can also be kind of up in the air. And so this is really not the time, not that there really ever is, but this, especially now, is not the time to be in the hospital, is what I tell my clients. So let's use our skills to keep you out of it. And we are decreasing the quality of life interfering behavior. So this is where the disordered eating, not going to work or school, substance use, chronic unemployment, all that kind of stuff. We are increasing the behaviors that will enable the client to have a life worth living. We are increasing the skillful behaviors that build relationships, to manage emotions, and deal effectively with all their other various life problems. Stage 2 is where we are treating the PTSD or trauma symptoms using a prolonged exposure sort of model, where we're building them up to memories of the past so that they're not getting emotionally dysregulated when they're thinking about it or talking about it. Stage 3 is about increasing their respect for self, setting their own goals outside of the life and therapy interfering behaviors, so that they can get to their life worth living, like career goals or relationship goals, that sort of thing. And just kind of like solving ordinary life problems. So in stage 3, we're kind of approaching more of what we would think is more typical of most therapy sessions. And then stage 4 is really that kind of like spiritual approach that Emily was talking about, where it's adding that extra degree of meaning to one's life. And really, a lot of clients and clinicians may even never really get to this stage. But DBT really like trademark stage 1, stage 2, and then to some degree, stage 3.
Behavior chain analysis, such a huge and important part of DBT therapy. It's actually one of my favorite things to do. So we start a behavior chain analysis with like identifying what the vulnerabilities were. So I think I mentioned this earlier before, like if you're not getting enough sleep, if you were on an alcohol bender the night before, you're not going to be at your best the next day. If you have stressors from previous days, obviously you're not going to be in the best place either. So you're looking at what brought you to the situation that made you a little more vulnerable to reacting. So then there's always a prompting event. A prompting event is the thing that happened that caused that the clients can identify as the cause of the response. Please don't mind my little friend here. Excuse me, sir. So after the prompting event happens, like what they'll usually tell you is that, like, I don't know, mom took my phone and then I went in my room and I cut myself. And you're like, whoa, 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 whoa. You're telling me that you flew to your room. There was nothing that happened between there and then. And so what you are asking them to do is they're saying, okay, your mom took your phone. At that point, did you feel anger? What did you feel? You kind of start to really break it down. And we'll go more into behavior chain analysis in our individual therapy and mindfulness training. But you really are breaking down. You felt anger. Okay. So when you felt anger, what did you do? Well, I yelled, it's not fair. Okay, so you yelled, it's not fair. Did that make you feel more angry or less angry? Oh, I was more angry. Okay, how did your parents react? They said, just give me the phone. Okay, well, when they said that, did you feel more or less angry? I felt more angry and I wanted to throw something. And then you just kind of go through all of the different pieces until they get to the place where they're actually self-harming or whatever their behavior is that they're engaging in. And the reason that you do that is because now you've got the series of events, internal and external. So you get the series of events, and now you can start to pick it apart. Like, look, there you had a unique opportunity where you could have used your distress tolerance skills. And so you're going through to figure out where can you start putting them, and then you even like maybe even have them play it out in imaginal exercise. Then you look at what were the consequences of the behavior. Okay, so you ran into the room and you self-harmed. All right, so you have this release of tension and now you're focused on this new harm, right? So you feel that release of tension. Now you called your boyfriend to tell him you self-harm, and he's giving you all this real lots of love and attention. Oh, I'm so sorry. Your parents are awful. I can't believe they did that to you. Like you're getting all this like validation and reinforcement, and you're eating it up like you're getting a treat like a dog, right? That's what I tell them too. And I'm not shy about it. I'm like, every time you do that, it's like you're giving yourself a treat for self-harming, and it increases the likelihood that continues. And then you take them one step further out. Okay, so all right, so that felt good in the moment, and you even validate it. Yes, it feels good when your boyfriend gives you all this attention and shows you how much he cares. I get that. Definitely feels good. And the last time you went down this road, it increased the likelihood you went to the hospital, your parents took you out of school, you went to get an evaluation, your parents wouldn't let you see your boyfriend or talk to him anymore. Like now there's like the short-term benefits are there, and the long-term consequences, those look a little rougher. Now, are these short-term consequences like worth the long-term ones? And then you kind of negotiate some of that stuff out. And it's really effective and it's really helpful because now you can justify why you need to use those skills on the back end or on the front end rather than waiting for the consequences that will happen. So here are the steps in the behavior chain analysis. First, you're describing the problem behavior. Then you're describing the prompting event. You start to list all your vulnerability factors. You describe the links. You describe the short-term positive consequences. You describe the long-term negative consequences. And then you look at solutions to the problem and come up with a prevention strategy. Right. So, and that's kind of what I meant by like, what skills would you put in there so that you can avoid this in the future? And what you often find too with your kids is they repeat the same pattern over and over again. Things look very similar and they're becoming more mindful of their own patterns, which means that when like, I don't know, let's say when they first start feeling mad and their heart starts beating and they start thinking everybody hates me, boom, there's my first sign that I need to implement a skill. And you'll see those same patterns kind of play out. And so they'll start to recognize them more. And then if you caused harm, how do you correct or overcorrect the harm? And what I mean by overcorrect is that you want to make sure that whatever harm you caused, you want to make it bigger so that the cost of the behavior is more than what you got from the behavior. So that's kind of why you overcorrect, because what you're trying to do is you're trying to input some consequences. So let's say you were in the waiting room and your therapist was running 10 minutes behind. So you decide to pick up a chair and throw it across the room. Okay, small harm, but definitely harm. So maybe overcorrection would be like, I'm going to come in here, I'm going to stay after session and I'm going to clean every single seat that there is and I'm going to put it back, right? Overcorrecting. And then you go into the deepest thoughts and feelings related to the behavior, like why it happened, how this was showing up, and you can explore that.
All right. And this is where, as a part of individual, we're creating those dialectical seesaws that we keep referring to. And this is kind of the part where I call it burning therapeutic calories. It's a workout therapeutically that when a client is leaning heavy on one side of the seesaw, we got to weigh just as heavy on the other side. So we're moving from their seesaw being like super uneven, and we're wanting to balance it out. So when they are in that sort of like space where they are, telling themselves they shouldn't feel that way, and they hate feeling this way, we're leaning in with those validation strategies and really allowing them to feel that way. But then they may come in the next time and they're really deep in those emotions, and that's where we're pushing more for that change, and we're not soaking in the emotions as much this week. They may come in and it's crisis after crisis after crisis, and we don't respond as though it's a crisis, and we're like, the go-to DBT line is, wow, that sounds like an excellent time for you to be using your DBT skills. And the next week they may come in and everything is great and everything is fine, and you really got to drill down and remind them that just last week the world was on fire. There's got to be a time that you were using your DBT skills to manage some distressful emotions. So this is a workout, but I think this is what makes DBT DBT, and I love doing it.
So there's several different strategies for keeping the balance. So the first one that we talk about is entering the paradox. And the paradox is that usually our clients will come in where there is a right and a wrong, a black and a white, and that's just the way that it is. So like if they're in an argument with their parents, either their parents right or they're right. There is no in between. But more than that, sometimes they'll come in with a relationship. It's an internal right or wrong, right? So I really, really love this boyfriend, but he's also violent. So he's maybe abusive. And so I can love him and have these feelings of love, and he's abusive. So what are we going to do with that? So it's not but, it's an and. And so we're starting to work with both sides of the equation. And then there's a use of metaphor. And I know probably if y'all are anything like me as a therapist, you use metaphors like all the time. And you're just trying to give them some way of conceptualizing something using imagery or something else that they can connect to. Another strategy is the devil advocate. The devil's advocate is that idea of like, are you sure that's what's going on? Or are you sure you can do this? Are you sure you can implement that skill? And like, you're trying to get them to argue in favor of the treatment. That is the whole point of it. Because again, they have a tendency to polarize their thinking. So, and if you're questioning them, it's that reverse psychology, right? If you're questioning them, they want to defend. And when you defend, your stance gets stronger. Extending is when they put something on the table where they don't want you to take it that seriously. Like, well, if they do that, I just might as well kill myself. Oh my God, you're going to kill yourself? That is terrible. What are we going to do? You know what I mean? It's like that. We're not just throwing around this stuff. Like, we are going to make a big deal about it so that they can back up. Wait, well, I'm not really going to kill myself. I'm just really upset. Okay. So we're going to start to change our language, change the way that we do things, which, y'all know how we talk to ourselves. It affects the way that we feel. Activating things like look at helping them to understand and activating different sides of themselves, like looking at the other side of the seesaw, or in wise mind, looking at the emotion mind and the rational mind. So you're activating different areas of their brain. That is the core principle of what the seesaw means, is that they're heavy on one side of the brain and you're working to activate the other. making lemonade out of lemons. That's not written on here, right? But that's what Jordan was just mentioning, where they're in this unrelenting crisis. It's never ending. There's always this huge big deal, and you're over here like, oh my God, this is the perfect opportunity for you to make a plan on how you're going to use your skills here. Perfect. Let's get to work. Right. And so you're not like sitting in their crisis with them, you're bringing them back to the skills. And then finally, allowing for natural change. And they'll sometimes your clients will bring up all the ways that they were before and talk about how they haven't been successful in the past and all these other types of things. And you can say, you know what, that was then, this is now, let's work on now.
All right, Consult Team. This is therapy for the therapist. The goal of Consult Team is to help team members apply all of these different principles from DBT. It allows us to speak a common language among each other and to really adhere to the model. So Consult Group meets once a week, and it's really about creating that culture of DBT and keeping each other accountable.
No, go ahead, Jordan.
And these are the agreements that we review every week within Consult Team. So we start our Consult Team with a mindfulness practice, and then we jump straight to an agreement. So the first being the dialectical agreement that we're bringing openness to varying viewpoints. There is no absolute truth, and there is a reality in the study of the dialectical and the middle path. And so these, this reflects our assumptions that there is no absolute truth within DBT. Our second assumption or agreement, is the consultation to the patient or the client. The primary goal of the team is to improve our own skills as DBT therapists. And we agree not to treat our clients as fragile. We treat team members as capable of speaking for themselves. And so this is really about empowering ourselves and our clients to using our DBT skills. We have the consistency agreement, and that is to agree to accept diversity and change as they occur, and that things are going to happen that change, and we must accept that. We observe each other's limits, we observe our own limits, and we agree not to judge others or criticize others for having different limits from our own. And the reason why we use limits and not boundaries is that limits can change. And so sometimes we may have a limit that's working, and the next week we may figure out things are not working as well, and we may need to enforce a different limit. The phenomenological empathy is that we agree to search for non-pejorative or phenomenological empathic interpretations of our clients, our own and each other's behaviors. So this is not where we're degrading or dehumanizing in the language that we use to describe our clients, because we're all just trying to do our best, and we have an understanding of the history that our clients have, and we can push for their change and push for them to approach their goals. And we also have to balance that out with validation and an understanding that they are really doing the best that they can with what they know. And then the fallibility agreement, that we are each fallible and we make mistakes. We're not perfect people. And we truly absorb and live in that compassion for ourselves and for other people. We're never going to be perfect DBT therapists.
Phone coaching is one of the best ways that we can get our clients to generalize their skills outside of session. So the whole purpose is to help them cope with their symptoms, and we actually encourage them to initiate phone contact with their individual therapist or their designated skills coach when they're in crisis. Now, I didn't say it's a 24/7 hotline, right? Like we're not always on. So each therapist will set their own hours and limits for when they're available. And we tell our clients too that it should be used thoughtfully. It is not so our clients can give us a call to chat about what went on in their day. If there's something that they can manage on their own, they should definitely be managing on their own. And I'll be honest with you, like a lot of times your clients will call you about some things that are just not within a phone coaching thing where they just kind of want to chat out something. And that's not what it's for. It is for when you are a crisis and you don't know what to do, please use this. And for that reason, we often set time limits on how long those phone coaching calls can be. For me, personally, I start off with not having a lot of expectations for the phone coaching. And then after one or two times, I'll be like, okay, by the time you call, you need to have already used 2 or 3 skills before you call me. And when you get on this phone, the first thing you need to report is what you have used. And this is to reduce the amount of like abuse of that privilege, because BBD clients in general, like they have a deficit sometimes of love. And so this is one of the things that they do is they'll reach out to kind of fill up their cup, but rather than to work through a situation. It's also during highly stressful circumstances like suicidal thinking where phone coaching can be most effective. So the therapist has a unique opportunity to kind of talk through these emotionally trying times so they can prevent like suicidal attempts or any like self-harm and maybe even prevent hospitalization. Which is super important because hospitalization can be very, very reinforcing for our clients and that they get a break from life. And so each time they go to the hospital, it actually increases the likelihood that they will return to the hospital. It also increases the likelihood that they'll make another suicide attempt because they do. And if you have teenage clients, more importantly is not only is it reinforcing for the client, it's reinforcing for the family. And when it's reinforcing for the family, that increases the likelihood that the family will engage in behaviors that would trigger the suicidal thoughts and self-injury behaviors in the kid. So like keeping all of that in mind, phone coaching is very effective for helping with these things. Therapists can guide clients to kind of apply their learned DBT skills, like their distress tolerance or their emotion dysregulation or emotion regulation skills, so they can avoid engaging in destructive behavior. Additionally, we have like suicidal call protocols. So if they are calling in for that reason that they're thinking, we can remove any of the like direct dangers. We can evaluate what the plan is, and we can help our clients in a moment of need. So there's 3 primary purposes. One is to reduce the suicidal self-harm behaviors. So they're, like I said, they're encouraged to call their therapist for support and skills coaching. The second is to get feedback and suggestions when they're practicing a skill. So they can call in and be like, hey, I am trying to use this tip skill. I'm not really feeling my stuff go down. What should I do? Well, maybe we extend the time that you put your face in the water to more than 2 seconds. So like you're just kind of helping them because sometimes like, you know, transferring of information, sometimes there's information breakdown, right? Where you think you conveyed what they needed and you didn't. So you're helping them to apply the skills effectively in real time. So that usually phone coaching is recommended whether they need practical assistance as they apply that learned skills. And then finally, it's there to strengthen the relationship with the therapist. So if there's ever like a problem in the therapeutic relationship that might be interfering with the treatment, and sometimes even like the therapist will be the one initiating the call on this. So if you've had a kind of a couple of funky sessions and you're like, hey, listen, I've been feeling some funkiness, let's work this stuff out so we can work through whatever is getting in the way of us doing the therapy. that can be really helpful and supportive to the client. And it's modeling appropriate behavior too for interpersonal effectiveness.
And that's it. We have so enjoyed this first training with y'all. Of course, reach out to us if you have any questions, and we look forward to working through our next presentations with you.